Okay, so I'm lecturing today from my office at the hospital, which is basically a closet. Um, this lecture will cover antihypertensives, and then the next lecture will cover the antilipidemics, and that will wrap up all of the material for the quiz that will open this weekend. Now, because we've been behind on things this weekend, or this week, at least I feel like we have been, um, I'm going to leave the quiz open all of next week in case you need a little extra study time. Of course, next week we'll begin a whole new set of difficult material, probably more difficult than this. It will be things like antibiotics. However, despite the fact that it seems that I like torturing you by throwing so much difficult information at you, once we get the current section and the next section out of the way, things will kind of be a little smoother sailing, so to speak. So, blood pressure, things that cause blood pressure. A lot of this, fortunately, is going to tie into what we discussed in the cardiac section. So, vasoconstriction, the smooth muscles constricting the vessels because your adrenaline, your glands, your adrenergic system, sympathetic system is acting in a way that it should not. So you're basically in a constant state of anxiety as far as your body's concerned, and it elevates your blood pressure by causing smooth muscle constriction. Too much water in the hose, for example. The use of diuretics is simply to remove water from the vasculature and therefore lower the blood pressure. Other issues can come from renal disease. A lot of people have elevated blood pressure with renal disease. In fact, my dialysis patients, I can gauge when they need dialysis off their blood pressure almost more than I can their creatinine. And it's really interesting to watch the trend. Both will go hand in hand. Renal artery stenosis is another problem. If you have a patient that you've thrown everything in the book at and their blood pressure is still insane high, get them to a nephrologist. They may have something like that going on. So, as far as the book goes, there's a chart on page 103, and it breaks down everything just like it has in the past few chapters, which I like that. But it's got a lot of medications on there. Not necessary to know them all. This is just like most other situations you need to know about drug class. So, on page 104, it talks about ACE inhibitors, and those I want to talk about first. So, angiotensin converting enzyme inhibitors, or ARBs, angiotensin receptor blockers. Like I said in the previous system, they work on the renin-aldosterone angiotensin system, the RAS, R-A-A-S. I think I said R-A-S in one lecture, sorry. If you picked up on that, you'll get a bonus point. These medications probably are going to be quite commonly prescribed. They also come with a lot of things that you have to watch for. So, first thing, they are good for blood pressure. We've already discussed that they're good for people who have heart failure because they, number one, help prevent remodeling of the left ventricle. Number two, they really reduce blood pressure through manipulating the aldosterones. Number three, the people that we've discussed, say our patient, for example, in the discussion board also had diabetes mellitus. So this is also renoprotective. ACE inhibitors can serve many good purposes all at the same time. So it's an excellent drug. Now, what's the number one side effect we always talk about with ACE inhibitors? The cough. So what is the mechanism of the cough that ACE inhibitors cause? You may submit that question to me in email form for bonus. And we'll apply, I'll either make that a 1% or 2%, but I know the reason, And you can know the reason, and it'll be a good thing to know this reason, okay? So research that. You can turn that in at any time in the next 2 weeks. Okay, so that's sideline. Now, things that you also want to remember about ACE inhibitors. They are potassium sparing. So things you want to consider. They also can contribute to renal failure. So here's a situation. We have a patient who is diabetic, they have hypertension, and they have heart failure. And trust me, y'all, this is common. These are commonly seen together. The little exercise we did is the patient you're going to see time and time and time again. Except for those of you who are telling me you want to do women and children, you probably won't see that. But so let's say this patient that we've been treating, our 75-year-old male, he's on, everyone's prescribing metformin, metoprolol or Coreg, lisinopril, and Lasix. I like all of that. So let's say he's been on those medications for 6 months now. He comes back to us and he doesn't actually have any symptoms. He feels great. And we run his lab work and his basic metabolic panel shows that his creatinine is 2.8. When we checked his basic metabolic panel on his last admission, it was 0.96. So it's gone from normal to not normal. And who cares what the BUN is? I'm worried about, we're talking about creatinine right now. So the patient's not having any symptoms. We checked the urinalysis. There's no urinary tract infection. He's probably not drinking water like he should, because every 75-year-old person says, I drink plenty of water, but they're not. So he's on a diuretic, a loop diuretic, Lasix. And it doesn't matter, even if you chose hydrochlorothiazide, that's still anything that will remove fluid from the body in a dehydrated state will impair your kidneys. Okay, well, we also have him on an ACE inhibitor, which can also impair renal function. And he's on an anti-hyperglycemic metformin. So 3 medications which can actually hinder his kidneys. Well, oh my gosh, you didn't tell me about this, or I wouldn't have selected any of those for the discussion board. Well, absolutely not. Prescribe any medicine until you have a reason not to. So we look further into his metabolic panel and we see that his potassium is normal. Why would that be? Well, Lasix gets rid of your potassium. Some of you are prescribing potassium supplements, which is fine. But the ACE inhibitor in this patient was actually retaining potassium, especially since his kidneys were becoming impaired from all 3 medications and his state of dehydration. So we have a normal potassium balance. Now, let's say that we've got a patient who simply has diabetes. This is a 58-year-old African-American female. She has diabetes and known kidney disease. Her baseline creatinine is 1.8. She comes into the office and it's 2.5. She's been on lisinopril. She's been on... she's not been on metformin because that didn't work, so she's probably on glyburide and... well, let's just say glyburide for now. Anyways, we can keep the glyburide going, but with reference to the ACE inhibitor, maybe time to stop that. She has chronic kidney disease. Now remember, chronic is chronic. You're not usually going to fix it, so at appropriate levels, it's fine, but hers is worsening, so in this case, let's stop the ACE inhibitor. Now in our CHF man, in his case, let's actually give him some fluids. He's too dry. Okay, those are some weird scenarios. I know it's not in the book, but I want you to think about these things. If we're getting into a situation where all the lines are about to start blurring, there's no black and white, these medications are going to treat several different diseases, and now they're going to start interacting with each other. So, ACE inhibitors are potassium sparing. What other thing could we treat our heart failure patient with that is potassium sparing? Aldactone. Now that was a diuretic that nobody picked on the discussion board, and rightly so, because it's not on the $4 list. I have seen patients who come in and the emergency room admits them, and they may come to your office with no complaints at all, and you're running routine blood work and their chemistry panel shows they've got a potassium of 6. Well, what in the world? They're on Lasix, so you think they should be getting rid of their potassium. But they were also on aldactone, which can help Lasix, and it helps spare potassium. And they were on lisinopril because of their low ejection fraction. So 2 potassium-sparing agents. And let's say, just to make it, classic, they're just like everybody else. They're not drinking water. They're on 2 diuretics. So their kidney function is a little bit impaired. So impaired kidneys retain potassium. So what we want to do in this situation is stop the aldactone, stop the lisinopril, and give the man some fluids. And then later on we can ease back onto those medications, just be a little more careful. Maybe he only needs the ACE inhibitor and Lasix and not the aldactone. Okay, I know that's a lot of jumbled up stuff. It won't be that jumbled up on the quiz, but those are things I want you to be aware of. Now, I may ask you some questions about ACE inhibitors. Which of these diuretics would you not want to give with an ACE inhibitor, or would you at least want to be cautious because of their kidneys or something like that? Patient, and listen, y'all, I'm going to start throwing some thinking questions. It's going to be information from the lectures and the test, but I want you to start thinking. I may say, like the examples I've just given you, this patient has impaired kidney function. He's on medicines X, Y, and Z's. Which one of these should we probably stop first? Now, I won't make it too complicated because, trust me, in that situation, there's probably X, Y, and Z need to be stopped. But I'll make it where one of them is pretty obvious if you're understanding the concept, okay? So, ACE inhibitors, ARBs, same principles. Again, if it sounds like April on the end, lisinopril, I guess it's not really April, that's April, but I always think of April, then it's an ACE inhibitor. If it sounds like Artin, like candesartan, losartan, those are angiotensin receptor blockers. ARBs, Artin, R. This is really weird looking at my face on the camera going R, R, R. I sound like a pirate. Okay. Now, quickly on to page 106 and 107, beta blockers.